Hello, welcome. We are waiting for people to join. Hello, welcome everybody. Welcome to this session. So, my name is Elise Lesieur. I'm working for Action contre la faim. I'm delighted to moderate this session on integrated and responsive nutrition services. Thanks for joining. I'm going to give you an overview of the session. We'll start with two 20-minute presentations of our distinguished speakers, and then we will have a Q&A session. So any questions that you have, you can put them in the Q&A box, and we will try to address as much as possible questions after the presentation. So we will start with the first presentation. The first presentation will be on CMAM Surge. We'll have the Kenyan example and information on the global overview of this methodology. So the speakers are Lucy Lafferty and Weldon Ngetich. Weldon is currently a nutrition specialist with Concern Worldwide in Kenya. He is an experienced public health nutritionist with over 10 years of experience in nutrition programming in Kenya and in other developing countries in Africa and Asia. Lucy Lafferty is the Global CMAM Surge Advisor at Concern Worldwide. She has previously worked for Concern as nutrition advisor in Burundi and Niger, supporting the setup of national scale-up of CMAM Surge. She has a background in clinical dietetics with a Master of Public Health Nutrition. Lucy, well done. The floor is yours, so you can start your presentation.
Thank you, Elsie. So good afternoon and good morning for those who are still in the morning. Welcome to this session. As mentioned, I'm presenting on CMAM Surge, one of the adaptations that we are implementing here in Kenya. We are using the term CMAM in Kenya because currently the service is already integrated in the primary healthcare service.
We don't see your presentation yet, Weldon.
Sorry, it's coming. Just a second.
Almost there. You can see it.
Great. Thank you. So this is what I was talking about. You see I've indicated CMAM as well as CMAM. So in Kenya, currently the management of wasting services is integrated in the primary healthcare service, and that's why for Kenya we talk more about CMAM. So basically, CMAM Surge is an approach, a system that provides support to the health facilities and sub-county teams when responding to deteriorating nutrition situation. So to do this, CMAM Surge approach adopts a series of steps that links analysis of the context, health system capacity, and needs with agreement on action and capacity support that is required. This analysis process normally allows the health facilities to be able to set thresholds that when crossed, it moves the health facility to an higher emergency phase and trigger pre-agreed actions and capacity. So actions are normally triggered whenever the facilities or the situation is deteriorating, and they are normally deactivated when the situation normalizes. The main objective of CMAM Surge is to strengthen the capacity of the health system to better anticipate, prepare for, and manage increased demand for CMAM services. It specifically looks on three key issues. The first one is to ensure preparedness, timeliness, and adequacy of the response. So when you talk about the adaptation, what exactly are we talking about? So as all of us know, CMAM services are often introduced in countries as an emergency, and has been directly implemented as a vertical program. However, we've seen an increasingly changing strategy where we see it's been integrated in the primary healthcare services and is scaled up as part of routine service for management of acute malnutrition. This is a significant change from the emergency focused response and often delivered with start-stop support funding. So in this case, IMAM Surge approach is a way of working with the system to strengthen service delivery and aims at providing more sustainable, less disjointed, and less emergency focused approaches. So specifically in terms of what we are looking at for the adaptation, the emergency situation based on IMAM Surge approach is that it's a factor of caseload and capacity. Secondly, it uses facility data to monitor and declare the emergency situation for each individual facility. So in this case, we are talking about each facility monitor their own situation and respond individually compared to a situation where we're seeing several other facilities or several contexts responding whenever we are using the WHO guidelines. So as I mentioned, this is a shift from the former where we normally trigger nutrition emergencies based on the GAM prevalence, where the SMART survey must have been done, and the data is normally at population level, and it's whenever we are having the response, it's applied to a wide area. So in the context of Kenya, we can talk about a bigger location like a sub-county level. So what is the coverage currently for IMAM Surge in Kenya? As a quick part of history, the IMAM Surge was piloted in Kenya from 2011 to 2014. That's after a big drought emergency that affected Kenya in 2011. So the pilot ran across 14 health facilities in one of the ASAL counties in Kenya. As we speak currently, we have IMAM Surge implemented in 10 ASAL counties, which bears the burden of high levels of acute malnutrition. And in those locations where we have 750 facilities, we are at 63%. So 473 facilities are currently implementing IMAM Surge across the high burden ASAL counties in Kenya. So what lessons have we learned so far? The first one is that we've seen strong government leadership from the time we were doing the pilot, and that fosters ownership and sustainability. Secondly, we've seen integration of IMAM Surge in the country strategic planning documents, so like the country national nutrition action plan, county nutrition action plan. We have integrated development plans for the county contingency plans. So in this way, it has enabled IMAM Surge to be given the right focus and at the same time potential for resource allocation. Finally, we've noted that the approach that we adopted in terms of the rollout, which was mentorship and continuous on-the-job training, has been a sustainable approach because it allows service delivery to continue during the setup process. So in terms of the ideal situation for setting up the adaptation, the context should at least be observing or seeing seasonal spikes, so recurrent spikes in prevalence of acute malnutrition. The IMAM Surge service has to have been introduced in and endorsed as a government standard health service or activity. Finally, the government health system should be functioning, especially to a moderate level during non-emergency times. What are the barriers and enablers? So in terms of the barriers, what has allowed us to be able to move this fast in terms of rolling out across the country? We've seen government, as I mentioned earlier, taking a strong leadership from the pilot to scale up level, and also both levels of government from national to county level. There has been a team at national level who has been provided a technical leadership and guidance, which enables the rollout to run smoothly. Finally, we have the toolkit that has allowed standardization of the approach whenever we are doing the rollout. Finally, in terms of the barriers, Kenya and especially ASAL context are facing frequent drought emergencies, meaning that periodically we have to pause the rollout and focus in terms of emergency response. And additionally, we've seen frequent change in capacity at the health facility, so staff moving. That means that we spend more time in terms of capacity building staff whenever a new staff is coming on board. Low resource allocation for nutrition is one other factor, especially from the sub-national level governments. So because of that one, we see funding of such actions remains still to be a challenge. Finally, we're seeing still the coverage of nutrition service, and especially IMAMs, still remains suboptimal, and because of the weak community level services. So that is on slide 8 in terms of what we are planning next, especially for the country. We are aiming to scale up across the health facilities. As I mentioned, we are at 63%, so there's still that 7% which we are aiming to fully scale up. And the second one is addressing the weakness in terms of the community level services. So we are planning learnings and researchers to be able to learn how best we can be able to strengthen the community linkage. With that, I want to allow my colleague Lucy to be able to share the global perspectives of CMAM Surge. Lucy.
Thanks, Weldon. So since the initial pilot in Kenya in 2012, CMAM Surge has been implemented in 12 countries by multiple NGOs and UN partners, with financial support from both development and emergency donors across humanitarian and development contexts, as you can see in the map that's projected on the screen now. So from the map, you can see that there's been particular scale up across the West African region. And in this area, it was initially piloted in Tawa in Niger in 2015 to better respond to the recurring food insecurity shocks. And so following the inclusion of CMAM Surge in DG ECHO's 2017 humanitarian implementation plan for West Africa, we saw CMAM Surge scaled up and integrated into nutrition programs across the region. So with this scale up, it was clear that there was a need for strong coordination mechanisms, both within countries and at a regional level. And so at a regional level, the CMAM Surge West African Task Force was, and this was led by Save the Children and is still operational. And following on from this, country level coordination mechanisms were also established in Mali, and Asia partners were implementing the approach at the same time. And so the objectives of these task forces have evolved over the years, but they mainly focus on the sharing and harmonization of good practices and tools and ensuring the continued contextualizations, needs and challenges, as each context is slightly different and the tools need to be adapted in consideration of that. So in 2019, a global CMAM Surge task force was launched, and this was to help further consolidate the learning that had already been happening in separate parts of primarily Africa, but also in Asia also. So slide, Weldon. And so as part of the global CMAM Surge task force, a work plan and learning agenda, which runs up until June 2023, has been established. And so it's clear over the past 8 years, there's a wealth of knowledge that's been generated. So it's now super important to capitalize on that information and take stock of what we have learned, especially as we consider bringing this adaptation to scale further. So a very brief overview of the 4 areas of inquiry within the learning agenda. So the first area is shifting from CMAM Surge to a more holistic health surge model and ensuring a better integration into health systems. So when we look at this area of inquiry, we'll be looking at the piloting of a set of health surge tools and also capitalizing on research that is ongoing, that Weldon mentioned earlier in Kenya, but also in Niger, where we're looking at the acceptability of the approach to health workers. The second area of inquiry is looking at the integration of CMAM Surge data and monitoring into existing early warning and early action mechanisms, with the objective of helping governments and partners to better detect and respond to nutrition emergencies earlier. The third area of inquiry uses CMAM Surge, is looking at how we use CMAM Surge to strengthen community level action and coordination. And so here we'll be looking at questions such as the impact of CMAM Surge on coverage of SAM and MAM programs, and also whether CMAM Surge trends analysis, for example, could be used to help early detection of wasting by triggering timely screening. So linking CMAM Surge in with things like the Mother MUEC approach, which was discussed earlier today. And so finally, the fourth area of inquiry culminates all of those separate areas and looks at improving specific CMAM Surge steps, where we will look in more detail at each of the 8 steps, what we have learned to date, and how they need to be improved or adapted. And the ultimate objective here is to inform a revised CMAM Surge operational guide. And we expect that that guide will be ready in around mid-2022, so in a year's time from here. So that's everything from Weldon and I. I'll hand you back to Elise now.
Thank you, Lucy. Thank you, Weldon. We'll go to the next presentation. So as just a reminder on the question, so you can share your question and park your question in the Q&A box. and we will address them after the next presentation. So the second presentation will cover the integration of wasting treatment into the health system and the challenge faced. The speakers are Marie Dalimonte and Alberta Nyaku. Alberta is a recognized global nutrition leader with over 25 years of public health and nutrition experience, supporting governments to strengthen systems in more than 20 countries across sub-Saharan Africa and Southeast Asia. Ms. Nyaku holds a Bachelor of Arts degree in Home Science and Sociology with the University of Ghana and a public health graduate certificate with Tulane University School of Hygiene and Tropical Medicine. Marie Dalimonte is a Senior Program Officer on the nutrition team at Resolvement, where she leads analytic work on the integration of nutrition within routine health services in alignment with universal health coverage goals, with a focus on sustainable financing for nutrition. She works with colleagues in the nutrition community to develop standardized and sustainable methods to track resources from nutrition across sectors to support taking cost-effective intervention to scale. Marie holds an MPH in Social and Behavior Science and Global Health from the Yale School of Public Health and a BS in Human Biology from the University of Toronto. Please, Alberta, you can start.
Thank you so much. Hello, everyone. I'm happy to be here today to speak about our work on integration of wasting treatment. In line with the Global Action Plan, UNICEF is working with partners to develop a guidance for countries to adapt to integrate wasting into the routine health system. So this presentation will focus on a partnership between UNICEF and the Results for Development, R4D. It is still work in progress, and we hope to get feedback from you, and the working draft will be available in coming months. So next slide, please. So our work is focusing on Objective 4 of the Global Action Plan framework. That is, by 2025, we will increase the coverage of wasting by 50% through strengthening health systems and integrating treatment into routine primary healthcare services. So how do we do this? Our operational questions were, how can this increase in coverage be achieved? And what does integration mean to any given country? What does it look like across countries? Next slide, please. And as discussed in day one of the conference, progress has been made over the last 20 years. There's a wealth of experience drawn on from many countries. And even, for example, the presentation just given on the Kenya's CMAM Surge approach, which is being scaled up globally as well. So, however, while many wasting treatment programs may be perceived to be integrated, the agenda still remains unfinished. So programs are often delivered and funded through the humanitarian mechanisms and also by NGOs. So for the next steps, I will hand over to my colleague Mary to present the experience in developing the resource guide and where we are to date. Thank you so much. Thank you, Mary.
Thank you, Alberta. And I hope everyone is able to see this. It's being a little bit glitchy. I hope it's full screen and that you can see it.
The PowerPoint is good now.
Very good. Okay, great.
Yeah, don't move anything.
Good.
Perfect.
I won't change. I had to unmute myself, but I think we're good. Hello, everybody. I'm very happy to talk through the resource guide objectives and what will be included as per Alberta's introduction. So we started with 3 objectives. So first is developing a common frame of reference for integration. So as Alberta mentioned, we've heard the term integration throughout yesterday and today in some other sessions. The challenge, in some initial scoping and foundation for this work was that the term gets used actually in different contexts and situations and different things. And so let's try, part of this aim is to coordinate around what do we mean by integration. The second objective is to document country experiences in support of peer learning. So again, as just discussed, integrating wasting treatment into routine health services has been part of the discussion for, since inception and kind of when CMAM was designed and for the last 15, 20 years. But not necessarily these learnings and examples coming together with, in a reference. So part of the goal is to draw on the experience that is there and learn from what country experiences. And then the third objective is to provide a resource for governments on how to approach integration and for partners on how to support. And so through this lens, it's a resource guide to think through what could integration look like in my country based on the current situation, what are the goals trying to achieve, and opportunities that exist. So we go through this in a systematic way, which I'll share more of soon. Okay, so to start by what we mean by integration. So we consider 2 dimensions of integration here in this guide, and this graphic is illustrating this. So there are 2 dimensions of integration. First is the idea of embedding vertical programs into broader child health platforms or health systems. And then the second is this transfer of responsibility from external partners to national governments. And so you can see both of these dimensions are along a spectrum. So it's not necessarily, integrated or not, but countries are at various stages in their roadmap, I suppose, to integration, and could be along a spectrum for both aims. What you see here is kind of an illustrative example. So on the extreme, we have NGO-driven vertical programming. So this is shown in the left-hand box. And then, we might think of this as the historic CMAM program. And then on the other hand is this teal box where wasting is completely embedded in primary health. It's completely government funded and operated, which, as we know, is rare for the highest burden countries that we see have the highest burden today. So, along these 2 axes, a couple points to make. So one, again, that countries are in different stages, are all in different stages, and integration is very context dependent. It's also not an all or nothing. So there are many forms of integration that are possible, and some may be appropriate depending on where a country currently is kind of in their stage of development. 2 principles are inherent with this definition: that integration must be a health sector priority. So within the health sector and health sector strengthening initiatives, kind of seeing wasting treatment as part of that, including all opportunities to screen and treat children for wasting. And then the second is that the process of integration must be led by country governments with support from partners. So these being 2 kind of key principles of driving the integration agenda. So why pursue integration and why it matters? So, important point that the guide makes is that integration is not an end goal in itself, but that integration can be important means to various end goals. So such as an increase in coverage and equity of the treatment of wasting, ensuring programmatic and financial sustainability, and also increasing program efficiencies and cost reductions. So when having these end goals in mind, constantly thinking about, does integration get us there? And all of this kind of contributing to broader universal health coverage or UHC agenda. And when we think about it in this way, in terms of integration being a means towards an end, it allows you to kind of think through and assess whether, what are the benefits of integration? And there is some evidence from some country examples where there sure are positive benefits that come from integrating wasting within health platforms. But then there are also cases of more mixed evidence. And so considering possible trade-offs, as kind of shown in this box on the bottom, but possible trade-offs to wasting programs, but also other health services is really critical when thinking about, thinking about integration and plans to do so. So for example, trade-offs could be a reduction in quality of services, or perhaps a trade-off to other health services. So when broader child health platforms or programs like IMCI, CCM, or any other kind of platforms, if they're doing more for wasting, does that mean a trade-off in any other health services, kind of to put it simply? And so the guide, as I'll discuss soon, kind of goes through a series of steps and questions to think through, what do we mean by integration in my context, and also, thinking carefully of, does this achieve the end goals that that we're establishing for ourselves? Okay, so the other point to make is that integration can be considered comprehensively across the health system, or it can be thought of within each health system component. And here we're seeing the 6 WHO health system components or building blocks, plus emergency preparedness. And so the resource guide is built out to think through what does integration look like for each of these areas. And as we just heard from the presentation earlier, we've added emergency preparedness because of the importance to wasting and the importance for governments to respond to surges in caseloads that aren't necessarily grand emergencies, but things that are more predictable or seasonal, to strengthen systems to respond to these kind of from a resiliency angle. I'm going to test out, so I'm going to talk through, let's see, we want to test out, I hope this works. We have a poll question for the audience, which I hope will be coming out. So we'd like to hear from you. So I've opened it, I believe, with the question of in countries that you work in. Okay, great. So in countries that you work in or support, which area do you think needs the most attention? And so I'm going to leave that open for you to respond. I'm going to talk through this slide as that's open, just to kind of think through, what would be a response. So in kind of developing this guide, we've heard several remaining priorities within each of these health system components. Try to summarize these quickly as you're thinking through how you would answer this question. So first, on leadership and governance, as we heard in this conference today, okay, great. So elevating wasting as a health priority. So is wasting present in national health sector plans, strategies, investments, and how do we increase government ownership of wasting treatment across health system components? This seems to be an overarching theme kind of within this component, but also across building blocks. For sustainable financing, there's the idea of shifting to more sustainable sources of financing. So this includes, but it is not only limited to increasing domestic funding, government funding for RUTF and broader programming needs, but also, we know a lot of the majority of the funding from external partners is still through humanitarian sources that comes with less predictable funding streams, as well as kind of shorter term investments. So it's kind of, within the broader sphere, how could we shift to more sustainable sources, not only kind of thinking about domestic sources, although that is kind of a significant question that we hear. Supplies and supply chains, thinking about RUTF as within national supply chain management and planning processes for other health studies. For information systems, thinking about wasting data as being collected and reported on and analyzed in parallel to other health, or in conjunction with other health data. So for example, looking at wasting burden trends, and does that track with where the other health burdens are, and does wasting get its fair share relative to other areas, or does this data help with program targeting for broader health programs and not just kind of the delivery of wasting treatment? On service delivery, Here, there's a big question about leveraging missed opportunities. We could put it that way in terms of, are any points of contact health workforce perspective very much linked to service delivery, but are community health workers consistently screening for nutritional deficiencies? Is it within job descriptions? Even when it is, are there capacities and trainings to do this effectively, or does it get bumped off of a long list of duties that community health workers are meant to deliver? Facility side, again, are all health workers trained to screen for wasting? For emergency preparedness, is very much in line with the surge approach, so the resiliency, and that we heard a lot from. So let's see. So I'm going to end the poll, and let's see if this works. So I'm not sure if you're able to see the responses on the screen, but it looks like sustainable financing received the most responses, followed by, I believe, leadership and governance, and supply chain. And thank you for everyone for filling this out. Let's see. And happy to respond to any questions. I'm getting a ping that we have only 3 minutes left. So let me flip to the resource guide. So the idea of this is to be a practical tool. So it will include a number of country examples for integration and key lessons learned. It will also include resources and tools for country teams to identify and assess integration actions, and then provide templates where possible and necessary. So we're trying to make this as practical and useful to country teams thinking about integration, how to action them. And just to kind of give a brief overview of the suggested approach, in terms of establishing, it starts with establishing a process of intended aims. The second step is to articulate, as I mentioned, the aims of integration and end goals. The third step is to take stock of the current situation. So here is where, understanding current constraints to programs across building blocks or within a health system component area, to understand what are the current constraints and does integration help achieve or have a benefit towards you achieving your goals. After this happens and kind of identifying the current situation, identify these possible integration actions and then assess them. So does this help you achieve your broader goals? And so this is very much kind of a high-level snapshot, but is meant to, start from at a starting point, kind of going through in a systematic way some of the key questions within each steps to to develop in the end a structured plan on what the integration action is, what do you mean to achieve, think through in a structured way what are the possible trade-offs, and do the benefits outweigh the trade-offs, to allow you and country teams to kind of develop a strong case for why integration or what integration could look like. So this is, I recognize a really quick snapshot of the guide, and we'll have it's still a work in progress, and we hope to share more soon. This is again developed with UNICEF and Lafferty, in addition to an external advisory group participating and reviewing, which I've seen a few of the names kind of as the attendance list. So thank you for joining, and we hope to be able to answer any questions that you have and stay in touch with those that would like to stay in touch. So I'll end here. Thank you.
Thank you, Mary. Thank you, Alberta, for your presentation. I think it's time for questions. There are already a certain number of questions in the Q&A box, but it's still time to send your question if you want to ask any complement of information. So maybe I will start with the first question for Weldon and Lucy. So there are several questions concerning MUAC mothers and community health workers. People would like to know how they can contribute to the CMAM Surge or IMAM Surge strategy. if one of you want to answer.
Thank you,
Well,
just
Elsie.
to clarify,
Maybe.
Elise, I think, are you referring to the learning?
Well done, go ahead.
Okay, thank you, Elise. So basically, yes, the question around integration of family work in CMAM Surge, I think, and this is something that we've been looking as a country program to, it's coming in as a strategy that has the potential to address the gaps that we see at the community level, because the biggest gap that we see at the community level is that the CHVs don't normally do the screening and referral. So in that case, some of the, and you can say that when you do the coverage survey, we still see a huge proportion of children who are not already enrolled in the nutrition program because of the weak community level engagement. So family work will come in handy because the mothers will be able to know, they'll be able to screen and be able to refer children for nutrition management. So basically, IMAM or CMAM Surge ensures the system is providing quality services. Family work will be able to trigger or ensure that the mothers are referring to the facility for management. So I think they play a strong complementary role.
And what about community health workers and maybe the link with ICCM Plus?
Yes, ICCM in Kenya. I know there was a session by my colleague to be able to share ICCM experience in Kenya. It's still at infancy stage. So we only had the pilot concluded last year. So far as a country, we've not been fully embarked in terms of rolling up ICCM across many counties. But I would say that yes, depending on how it can play out at the community in terms of the community health workers managing cases, that can also be a strong way of ensuring that the community level services are strengthened. But not yet in Kenya. We've just finalized the study and we are sharing to see if the country will be taking the direction to be able to adapt ICCM as an approach.
Lucy, do you want to complement what Weldon said?
I think Weldon has covered the key points, and if I captured well at the end of your question, it may have been in relation to contributing to the learning agenda. And so definitely we want to be able to capture other pieces of research or evaluations that are ongoing that link CMAM Surge to other activities. And so primarily we're doing that through the task force that are already in place, but we're aware that that doesn't capture everybody who potentially has information to contribute. So definitely if anyone has anything, we'd love to hear from them. And I can be contacted on that.
Maybe just another question for you, Lucy. There is Lou Baba who is asking if CMAM Surge is applicable in a country where there is no strong health system.
So it's a very good question, and it's something we're looking into. So previously, I think we were always generally saying that for CMAM Surge to be integrated, it definitely needed that solid foundation of a health system that was somewhat functioning. And within a current program that we're exploring at the moment, we're looking at how we can adapt some of the key steps of CMAM Surge to contexts where that health system is less functional. So I don't have a response immediately to it, but I think there's definitely components that are useful. The model as it is at the moment, potentially it's not ready to be applied, but I think in many of the steps can definitely be applied. And we're going to be looking at that in South Sudan and in DRC, where I think we'll hopefully have some very interesting lessons learned from those two contexts.
Thank you, Lucy. Then we have a question for Mary and Alberta. Learning for the numerous global resources guidelines that have been developed since 2007, what are the value addition of preparing for this particular global guidance? With demand for a context-specific and regionally evidence approach to treatment of severe wasting, would this process be best fit to the structure of a country or regional resources guide?
Thank you. Thank you for this question. It's an important one. So it's not meant to replace guidance on any protocols or things like that, if I understand the question. What this is meant to do is to suggest a process. So while, you know, there are, you know, the treatment protocols, I mean, in conjunction with, you know, alternate approaches, you know, how do we move from where we currently are to strengthening health systems to do more for wasting? And so really it's kind of needs to be bottom up, a sense. So this is a resource guide for country planning, where the assessment of the current situation, the identification of options, and the assessment needs to happen at that level. And so this is, again, this is a global guidance and a suggested structure drawing on experiences and examples from countries, but in a way that it's kind of bringing those examples together so that other countries can learn from it. We see it very much as kind of a live iterative tool. So, you know, as we kind of sought out to do this, you know, integration being high on the agenda for scaling wasting treatment and, you know, achieving the Global Action Plan goals. However, there's very limited operational guidance on how do we do this, and kind of what do we do, and how do we coordinate with our counterparts, you know, with government, UNICEF, other UN agencies, as well as external, as well as NGOs and donors. And so how do we have kind of a coordinated plan on integration across all of the building blocks, or any one priority, including, for example, financing, and go through it in a kind of a structured way in terms of, for my country, this is what I want to achieve under the umbrella of achieving our integration goals, and how do we do it? So really it's kind of a suggested process with tools and information and questions to guide along the way, but would need to be developed at the country level. I hope this answers your question.
Thank you. Alberta, do you want to add to this response? Okay, if no, I will go to the next question. There are two questions on CMAM concerning the link with on CMAM Surge, IMAM Surge, concerning the link with health. So the two questions are what you talk already about that, Lucy, but maybe it's good to remind a bit what is and how you plan to include health in your Surge model first. And the second question is about COVID-19 and how you were in capacity to manage the COVID-19 crisis with the CMAM Surge model.
Lucy, do you want to talk on the health surge?
Thanks, Elise.
Then I can talk.
Perfect, Weldon. So on the health surge model, how we're planning to include health in it. So it's something that we're exploring at the moment. And it's always important to remember that health has been a component of the CMAM Surge model in regards to the fact that we have been tracking those childhood illnesses and how they're linked to severe acute malnutrition. And so now when we reflect on how to make it more adaptive, looking at other illnesses, it's trying to see how we can best put in place those steps to apply them to other morbidities such as malaria or diarrhea, which are putting a large burden on the health facility. So putting in place thresholds, for example, for malaria, so that action plans at a health facility level can be easily triggered. Also, when we look at integrate or adapting the surge model to health, it's important to remember that there are all of the pre-existing surveillance systems in place, and we definitely do not want to replace any of those. Rather, we want to really focus on the quality of care that's been provided at a health facility level, and how the surge model can enforce the quality of care that's been provided through the reorientation of resources at a health facility level. Briefly on the question regarding COVID, so in Niger, actually, we try to see with the surge model how we could potentially use the information that was being collected on a weekly, monthly basis, for example, with the acute respiratory infection cases. And so we tried to collect them on a more regular basis to see if we were seeing spikes that had previously not been there. Also looking at the capacity step being how we now needed to review the capacity of the health facility, considering that other considerations needed to be taken into account. So each of the steps, we worked through them and we thought of what we could do.
It looks like we've lost our facilitator.
Okay, so I think it's actually Elsie. I thought my connection had dropped, but I think it's Elise who has disappeared. So just finishing what I was saying there with regards to the adaptation of CMAM Surge with regards to COVID. We looked at each of the separate steps and we looked at how we could adapt them to better respond to the changing environment of COVID. And one of the things I think that came out of it was the fact that actually with the trends analysis for CMAM Surge, one of the things that we had always had in place were these upward trends of caseloads. And what we all have realized with the COVID pandemic is that actually we were seeing a dip in the number of cases that were presenting at health facilities. And it was this reflection around the need that actually it would be very useful to have a lower threshold, which could trigger certain actions to investigate the cause of why people weren't coming to the health facility. So Weldon, I don't know if you have anything else to add on either the health component or the adaptation to in the context of COVID.
Yes, so for us in Kenya, lucky enough, most of the ASAL counties last year were facing a stable food security situation. So in that case, they didn't have huge cases of acute malnutrition. And secondly, apart from Turkana County, which is a host to a big refugee camp in Kenya, the hotspot for COVID-19 was only Nairobi and some other non-ASAL counties. So in that context, as much as we saw COVID affecting service delivery initially because of the fear, mothers fearing to come to the health facility and that confusion before the information had saturated the counties, that was the only effect in terms of COVID for service delivery. But then after that, we were able to produce that national level guidance to allow continuity of nutrition services during the context of COVID-19, and actually contextualization or adaptation in terms of the CMAM Surge steps was done. So in terms of how the different steps that I had mentioned earlier was conducted, with a few of reducing infection or adhering to infection and prevention control measures. So for us, we didn't see per se as affecting the nutrition COVID-19 coming to impact directly nutrition service delivery, but then adjustments were done to ensure that at least continuity of nutrition service delivery, while at the same time adhering to prevention guidelines.
Thank you, Weldon. Maybe a last question is for you, Mary. What do you think of the feedback provided following your poll question that financial aspect funding is one of the main pain points for ensuring integration malnutrition in the health system?
Thank you. Yes, I'm glad I came back to the poll. So it tracks with what we've heard. I think consistently sustainable financing for the treatment of wasting has been kind of key on the agenda of, the longer term plans. Where do we see ourselves in 10, 20 years in terms of financing and sustainability of the program? Financing is a key aspect of that. So it certainly tracks with what we've heard as a priority. The question, so there, we could talk for a whole hour on sustainable financing for wasting, and I'd be happy to. The question of fiscal space, so country governments, room in their health budgets for wasting treatment. We know that the cost of our UTF is large, and currently, very few country governments are paying for our UTF out of domestic budgets. I think the question also points to COVID and other priorities and competing priorities on health budgets in terms of the needs to invest their funding in priority areas. So it's a complicated question. So fiscal space is limited. We have to think about this in terms of a country's economic growth and trajectory of healthcare spending overall, and where does wasting fit within that? Currently, it's very reliant on donor assistance. But that donor assistance also comes often in the channel of humanitarian aid. So if we think about the longer term trajectory, there are things still to do in the shorter medium term to improve sustainable sources of funding that don't all as to, it's going to take a long time to get to 100% funding from domestic government. So how do we think about this in terms of a roadmap? And then also to say, I think, there are elements of system strengthening and financial management and budgeting processes that can be done in terms of thinking through what kind of technical support is needed to country planning teams to ensure that, when health budgets and child health programs are designed and wasting being part of that, how is that being costed, and is it being included in the annual budget processes, even when it's funded by development partners? I think there's still a lot of room to think about system strengthenings and financial capacity.
Yeah.
Thank you, Mary. Alberta, you want to add?
Yeah, just a quick one, that the previous question on what the value add is with all these numerous guidance that we have over the years. So one of the, added value is actually the whole sustainable financing and the leadership and governance. So this guidance would really, we hope, is going to help countries to really come up with a more systematic approach in planning the integration into the routine system, and as well as having government in the driving seat. Right now, it is still the humanitarian approach and the NGOs really guiding and leading this whole process. And so that's one of the aims of coming up with this global guidance. Over.
Thank you, Alberta. Well, that brings us to the end of the session. Thank you very much for your active participation and for your question. A big thanks to Marie, Alberta, Lucy, and Weldon for their presentation and for their response to your question. You can now join the panel discussion. This is the final session of the day on the main stage, and it will start in 3 minutes. You can access it in the agenda and information tab on the left-hand side of the screen. Thank you very much. Bye-bye.
Thank you.
Thank you. Bye-bye.